So thanks so much for letting me talk to you all today. I know I've presented to Rotary several times on the opioid response team, but this is actually my full-time job. Opioid response team is kind of like a side job. Actually, if you were to pull up my job description, you wouldn't see anything related to the opioid response team on there. And so I'm excited to kind of share what I do for a living. And just to kind of set the stage of why you should listen to what I'm saying, I have a little bit of a bio here. So I've actually been a nurse in Bennington for 17 years. And I've had a background in long-term care, home health, nursing education. I actually taught at Southern Vermont College for a couple of years. I've done research, community health, population health, and I'm currently the Director of Bennington Blueprint at Southwestern Vermont Medical Center. So I oversee the Vermont Blueprint for Health program in Bennington. I have my doctorate degree in nursing, and I got that in 2017. I have a master's degree in nurse executive track, and I'm currently halfway through a postdoctorate certificate in population health. I'm a published author in the Journal of Nursing Administration, and I was named one of Vermont's 40 Under 40 Rising Stars in 2018. I co-chair the Bennington Accountable Community for Health, and I'm the project director for the Bennington Opioid Response Team. I also serve on the board of United Counseling Service and Green Mountain Community Network. And so just a little disclaimer that what I'm presenting on today are my own views and opinions. And then I have a significant limitation, which is I'm a Benningtonian. And what does that mean? That means I haven't left. I was born and raised here. I'm actually 8th generation Benningtonian. But don't fact check me. That came from my mom and I didn't check her sources. And these photos you see here are from my grandparents' farm, my favorite place to go. And so I grew up in the west end of Bennington out by the airport. And we didn't lock our doors. And the most disruptive sounds were cows mooing in the distance. And I'm pausing and being more elaborate about this description because you'll see in a minute when I get into my presentation on why. I grew up in a middle-class family, loving family, went to public school, graduated from MAU, went to college. 2008, I moved to my current home, which is on the east end of town, right in town. And I had 2 children. And then there were a few things that happened around that time where, being a nurse in the community, I would have said, I know my town, I know Bennington. But it wasn't until my children went to Bennington Elementary, I got a new job as a home health nurse, and we moved into this home that I realized I don't know Bennington. And I share that because it's possible to be an 8th generation Benningtonian and not know Bennington. And you can really find yourself isolated from knowing the social emergencies in your town. And so I don't want it to seem all doom and gloom. We just have work to do together to have a thriving community. And some of that work is through population health, and that's what I'm going to talk about today. So I'm going to talk about what is population health, what are determinants of health, and what are the social determinants of health. And then I'm going to show you population health in action here in Bennington. So what is population health? A lot of folks think they know what population health means. Some think that's just public health, it's the same thing. Or as my 11-year-old son is convinced that I'm involved in population control. So it's kind of an ambiguous term, but it's actually becoming a specialty in healthcare, this population health perspective. And so the simple definition, if you were to Google what is population health, it's the health status of a group. But if we changed it from being called population health and changed it to be called population focused practice, then you start to see it's health management of a specific population, and it's a systems thinking approach. And it's best viewed as a triad of systems. It's healthcare, public health, and health policy. And I'll get into those a little bit more. So if we define the healthcare piece of population health, that's the clinical healthcare systems. These are your traditional healthcare systems, often individual focused health services. Examples are preventative care, screenings, medications, behavioral counseling. Public health, a traditional public health system, is community-focused health promotion and disease prevention. So communicable disease control, we're seeing it right now with COVID-19, environmental hazard response, food and drug safety. And then health policy is public policy, secondary impacts on health, and it increases access to health services, education, and some changes in tax laws. So population health isn't separate from these, it's combined. So it's that triad of systems, and that's why we label it population health. The number one question I get is, why is this a thing now? And the most obvious reason is because of the evolution of healthcare and healthcare reform. So healthcare is no longer reimbursed based on volume. Some of it still is, let me clarify, but it is evolving into being a value-based system. So you're having value-based payment reform and value-based healthcare delivery reform. So that's how we pay for services and how we deliver services. And so as a clinical person, it's really exciting to see healthcare evolve to what it really should be, right? Are we making an impact on folks? Are we improving the healthcare? Not how many people do we have in our hospital? And so it's an exciting time to be in healthcare, but it's also incredibly uncertain time because folks that were so savvy with that volume-based system are kind of at a loss for this value-based system. And so that's where population health comes into play. And I'm going to get a little bit more into that. And so this is the determinants of health slide. There's two times in my career that I call defining non-clinical time, meaning I've had many defining moments clinical related, like taking care of people or seeing things, but this is sort of the non-clinical defining times. The first defining time as a nurse was when someone talked to me about healthcare costs. This was an administration person talking to me about the cost of my patients as a frontline nurse. It was about 5 to 6 years into my career, around 2009, 2010. Can anyone guess why all of a sudden someone was talking to me about healthcare cost in 2009? Can we all remember what happened in 2009, 2010? Affordable Care Act. I knew someone would get it. The Affordable Care Act resulted in significant reduction in payment and started the path of evolving to value-based system of care. And so previously, 5 to 6 years as a nurse, I just took care of my patients. I gave them their medications. I treated their social and emotional needs. I just did what I was supposed to do as a nurse. I never had to think about cost. I didn't think about, oh, if I choose this particular supply, I need to make sure I have it last. Or, oh, we should talk to a pharmacist about changing your medication because it's too expensive. I didn't have to worry about those things. But in 2009, that changed. The other non-clinical time in my life, in my career, was this slide. No joke. It's this slide right here. So this is the determinants of health. And you can see we have policies and programs, health factors, health outcomes, all leading to 50% length of life, 50% quality of life. Look at these health factors broken out here. Health behaviors, which is tobacco use, diet and exercise, clinical care, access and quality. Socio and economic factors make up 40%, education, employment, income, family and social support, community safety, and then your physical environment makes up 10%. Why this was so impactful for me as a nurse was this right here. All of my work I was doing to improve the health of our population was 20%. And that's if they got to me. So access to care, were folks actually getting to me providing them care? So let's say less than 20% of what I'm doing as a healthcare provider actually impacts somebody's health outcomes. And that to me just completely changed the game and really led me down the path of population health. I want to pause. Any questions? Okay. So we're going to get into what are the social determinants of health. And this is also just a shameless plug to show you my puppies and my daughter, Eva. So the social determinants of health are life-enhancing resources. So they effectively determine your length and quality of life, and they are responsible for the most national and global health disparities and inequities. And so you can see if you Google social determinants of health, you're going to see similar, but perhaps different, but they all kind of mean the same thing. So economic stability, and I'll break these down a little bit further, social and community context, neighborhood and environment, healthcare, and education. So these are your social determinants of health. And what we're recognizing is that if we do not address these, folks are not in a good place to be able to address their health needs. So example, if someone doesn't have a home, if someone doesn't have food, do you think they're going to want to talk to us about, hey, your blood pressure is really high? Definitely not. And I don't know why my slides are advancing without me doing it. I apologize. All right, I have a little YouTube video, but I'm not going to show you because I don't have enough time. But I'll send this to you all to watch. And this is just a visual of social determinants of health. So I stole this from the Kaiser Family Foundation, and I feel like it's the best breakdown I've seen of social determinants of health. So under that economic stability piece, it breaks it down. Employment, income, expenses, debt, medical bills, support. I love the fact that it includes debt, because you could have employment and steady income, but if you have crippling debt, that is also going to impact your ability to take care of yourself and to meet your medical needs. Neighborhood and physical environment are housing, transportation, safety, parks, playgrounds. People don't often think about parks, playgrounds, walkability. Your zip code and geography can determine your health. I actually just taught a class at Bennington College. I was a guest lecturer talking about, does zip code matter when it comes to your health? And it does. Education, literacy, language, is it culturally appropriate language? Early childhood education, that's like the gold standard, early childhood education for upstream efforts. Vocational training, higher education, food, hunger, access to healthy options. And then the community and social context is quite a big topic, and I could do a whole other presentation on this. So this is social integration, support systems, community engagement, discrimination, and stress. So if folks are consistently under stress, they are more likely to be unhealthy. And then, of course, the healthcare system. Do you have health coverage? Do you have insurance? Do you have a provider? I just read on Facebook the other day how folks cannot find a primary care provider. And that is a statewide problem, regional problem. And then, are those healthcare systems providing linguistic and cultural competence care? And then, of course, the quality of care. And so all of those bundled together are the health outcomes, which is impacting mortality, morbidity, life expectancy, healthcare expenditures, health status, functional limitations. So one example I wanted to point out specific to Bennington on this slide was this community and social context. One of the things that we see in Bennington is a significant issue with oral health. And when you peel back the layers of oral health, in particular our low socioeconomic community members, oral health is not a top priority. In fact, it's culturally acceptable to lose your teeth in young adulthood, to just no longer have teeth. All your friends have them, your family, they don't have any teeth. And so that's a significant social context impacting health. And I just like this visual. This is the upstream, midstream, downstream visual for you all. And so upstream is going to be the community impact. What can we do collectively to improve our community conditions? Upstream is also significantly health policy. You know, when I peel back the layers of this work of population health, it always goes down to health policy. Funding for early education, town planning, community development, housing, income enhancement, supplements, employment, all come from health policy. And actually, recently, there's an initiative called Health in All Policies, where any policy creation has to be sort of cross-checked with what type of health impacts could that policy create. And I'm so interested in this that I'm actually thinking about going back to school for health policy. Don't tell Dan, he'll kill me. But it really is, if you peel it back, it really goes, we can only do so much as a community if we're not, if we don't have the health policies to support the work that we're trying to do. So I want to show you a couple examples of population health. I'm just checking my time. I'm actually doing all right. So any questions before I go on? Okay. So here is Vermont. This is county health rankings. You can Google county health rankings and you will see this. This is publicly available. And you can see on the left-hand side is our length of life and quality of life. Bennington is, I think, 12th out of 13 in here. It doesn't explicitly say, but I know we are almost the last, like the worst out of the entire state. And that always surprises folks, that we have the worst quality of life and the worst health outcomes. And if you all look at this map, what do you see when we think about, does your zip code impact your health? What do you notice about these areas? Up here, isolation, extremely rural, probably don't have access to healthcare. We can make a lot of assumptions with this slide. Here, what do we have right here? Burlington, UVM, a little bit more affluent, probably have access and jobs and money. Down here, you know, same deal. We're rural. We don't have a lot of access. We have a lot of unemployment. And then if you look over here on the health behaviors, clinical care, social and economic factors, and physical environment, I can tell you we're completely last on this. And I don't know why. We can, again, make assumptions on why this is. Why is Bennington so bad with our health outcomes? All right. So this is the program that I oversee, and I apologize. The next few slides are going to be visually a lot, but I'll talk you through them. So this is our Bennington Blueprint dashboard. I oversee the Vermont Blueprint for Health in Bennington Health Service area. And the Vermont Blueprint for Health has been around since 2008, way ahead of its time with population health initiatives. We are funded by Medicaid, Medicare, MVP, Blue Cross Blue Shield, pretty much all the insurers in a value-based payment model, not volume-based. So I don't have to do any billing. I don't give them my FTEs. They just give me $3 million and they say, do a good job. It's great, right? It's a great job. So here's what we do with that money. We provide embedded RN case managers, dietitian, behavioral health therapists into these practices that you see listed here. In addition, those practices also receive an incentive payment to be a part of Blueprint. I don't personally get $3 million. The community gets $3 million. But it's a significant program that I want folks to know exists and actually does a really great job for the community. We also have some self-management programs that are free. You don't need a referral. You don't need to have insurance. It's tobacco cessation. We have a pre-diabetes program going on. We have 2 classes. Andrea Malinowski is teaching them. They're very successful. People are loving it. And then I just have our team and our goals. So I would hand this out in paper if we were together. I would say, here's our dashboard. So that's Blueprint for Health is all throughout the state. There's 13 health service areas. So you would find my counterpart in each of those areas doing the same work. I am the co-chair of the Bennington Community Collaborative. And that is our accountable community for health. It's really born out of the all-payer model goals, which is to increase access to primary care, reduce deaths related to suicide and drug overdose, reduce the prevalence of morbidity and chronic disease. So we meet all of these community partners that we have listed, all of the CEOs, executive directors, leaders come to this 6 times a year meeting, and we talk about our all-payer model goals and our measures, but we've also started to integrate, those should look familiar, social determinants of health, housing, food, transportation, priority populations, education, environment, and community infrastructure. I'm also happy to send these slides because I realize I'm going through them fast. So some of this data has not been updated because our Bennington Community Collaborative has been very focused on COVID-19 response. So we're actually using a COVID-19 dashboard right now, and this one is sort of waiting in the wings. So you'll see I haven't revised it since October. This is our back page of our all-payer model data and measures and how well we're doing. So this is just a quick snapshot of the bold red items you can see is where we really need to improve. So Vermont Medicaid adolescent well-care visits were pretty low. Obviously reduced deaths from overdose, reduced deaths from suicide. And then of course our prevalence of COPD, diabetes, hypertension is statistically higher in Bennington. And then of course I presented on this, so I have to talk about it. The Bennington Opioid Response Team is another population health effort that's in action. We've been around since spring of 2018 and broke out into subcommittees, which are Youth Subcommittee, Recovery Housing Subcommittee, Law Enforcement Subcommittee, and now our Community Action Grant Subcommittee. So I wanted to share the Community Action Grant Subcommittee because you can clearly see sort of the integration of social determinants of health and sort of innovative ways of thinking to address this problem. So through the Community Action Grant, we're delivering community-based education. We're delivering school-based education. We're involving a liaison, a nurse liaison to help individuals with opioid use disorder navigate the health system. We have a Messages for Me texting platform. We just hired a community health navigator to assist individuals with substance use disorder to get resources focused on social determinants of health. And then we have an outreach for overdose project. And that's where first responders that are going to a suspected overdose are paging a peer recovery coach in Turning Point to come out to the scene where they're able to engage that person into signing a release form for UCS to reach out to them afterwards. And then we have some other tactics down at the bottom, which is to increase access to treatment and to create a recovery-friendly workplace program. And then this is our data so far. We did a Stand Up to Drugs flyer distribution. We have an educational event planned for spring, summer. We're working on a website. We did one education training through the Collaborative and ACT did that. They had 68 participants on a Zoom. This is a middle school and high schoolers, 68 on a Zoom after school, which was great. When they said they wanted to do a webinar, I was like, I don't know if people are gonna go to that. They definitely proved me wrong. Down at the bottom, outreach for overdose. We are collecting data on how we're doing with that initiative. Turning Point has 7 recovery coaches. And then of course the non-fatal data that we have. We've had 3 non-fatal overdoses since March 2021. We had 45 last year, 57 in 2019. The one thing I want to say about the non-fatal overdose data is that it's not conclusive. We have to estimate that there's a significant amount that we don't know about because of access to Narcan. Our fatal overdoses, I'm sure you read in the front page of the banner today, that fatal overdoses related to opioids was the highest for the state in 2020. We actually went down in our number. So in 2020, we lost 9 community members. 2019, we lost 11. And so far in this year, unfortunately, I think that this is projecting to be a larger number for 2021. We've lost 4 of our community members. We do plan to share this again at the select board meeting soon, I think at the end of April. So we'll have even more data on that. That's it. That was a lot of information. Any questions?
Kristi?
Yeah.
Are you with me? I have a question. Dean Hanson talking with you. One of your earlier slides showed health conditions in the state of Vermont, and it showed Bennington County area as being in dark color.
Yeah.
And way up at the top of Vermont is the Northeast Kingdom was also in dark color. And you said you didn't understand why Bennington would be that way. Well, I have family that live in that Northeast Kingdom area, and I can tell you that they don't begin to have the health care contacts or the qualities of care that we have, or even the services that are available that we have in Bennington. So it is perplexing to think that we would even be the same color shade with that much difference. Any comments?
I agree, Dean. It is. And that's why, I mean, we can make assumptions on what's really happening. You know, I do know that we're one of the oldest populations in Vermont, in Bennington, but that doesn't account for the quality of life piece of that data.
Well, there's some very senior centers up in that Northeast Kingdom as well, you know, and the hospitals are spread out. There's one in Newport and one in St. Johnsbury, and that's all. And people from the whole area have to travel to those too. And the smaller communities don't have anything like Manchester having several services, and Wilmington having service also. It's kind of perplexing, and Brattleboro is well protected. So it's interesting that there should be that difference.
Yeah.
Kristi, a quick question.
Yeah.
The Bennington Oral Health Coalition still around, and are you working with them?
Yeah, the Bennington Oral Health Coalition was a part of our original oral health subcommittee, which was, we had found an oral health grant through the state, and they partnered with us, and we're a great partner with that. But unfortunately, immediately after COVID-19 happened. We'll get back to it.
Mm-hmm. Yeah, I mean, oral health is such a huge predictor of other outcomes. I mean, for example, a lot of people who have bad teeth feel that they can't go to a job interview because they will feel they'll be discriminated against. So that is, it's not surprising, such a huge predictor. It is surprising to me that what you said, there's a cultural factor involved, that is acceptable, and that how do you try and change some of that underlying cultural belief system?
I think it certainly comes from the opportunity there with early education with the children of that population, just to try to change that sort of social norm that's going on.
I think.
Yeah, can I ask us on a related note, Kristi? You said it's a regional issue, it's a state issue that we're lacking in primary care physicians. I don't know if it's physicians or practices or both. We know that that's also true of dentists and pediatric dentists, especially. It was a really big deal, a huge win when we got the dental clinic at SVMC and we're able to recruit another dentist. Relating that to kind of community development, what do we need to do, or do you know from the hospital's perspective, what are the barriers to recruiting medical professionals?
Yeah, I mean, I certainly can't speak for the hospital, but my own opinion would be just providers aren't wanting to go into primary care field. It's a difficult field to get into, and as far as you know, how much money you get paid in that role. It's a difficult role to have. You have, thousands of patients on your panel. It's just not appealing for new providers. But I do know that the state is doing a lot of work on sort of, rewarding folks that do get into that field. So I know there's a focus on it, even on the ACO level. They're talking about how to recruit providers. And when I say providers, I mean physicians, nurse practitioners, and PAs.
Is it true? Is it also specialists? I mean, I only know from like gastroenterology that it's been really hard to hold on to a gastroenterologist.
Yeah, I would say that's probably more of a geographical thing with the specialist, because if you think about the positions that are available probably in larger hospitals in Albany and Dartmouth, they're probably scooping up those specialists more so than Bennington is.
Well, one thing I've heard, and this is, relates to Rotary, is that a lot of professionals move to Bennington and they find it hard to find a community. There's a woman who is a vice president of development at SVC, and she said she almost moved away from Bennington because she and her husband couldn't make friends. I'm thinking, well, Rotary is a really great place to become connected with the community. And, if there's anything we can do in terms of helping people, even on that level, just send them our way, of course.
Yeah.
To develop more connections with the hospital and associated healthcare practices.
So I know that Beth is working on welcome wagon ideas and welcome folks, but I wanted just to tap into one thing that I think is similar to the Northeast Kingdom. I sometimes call us the Southwest Queendom because, every kingdom needs a queendom. But I also am concerned about the rural areas in healthcare. I live in the very small town of Sandgate. When we were doing community needs assessment with the hospital, there's a red line. If you have a stroke or you have a heart attack past this geographic line, the chances of you surviving it decrease substantially. So I am concerned about the rural areas and, want to continue to try and challenge us a little bit on how we bring healthcare or how we are able to help those that are in the Ruperts, the Sandgates, the Paulets, the areas that are really even, the Sunderlands, that are really isolated. We have a lot of elderly people there and, continue to be challenged as neighbor to neighbor to try and keep people healthy. So I think that's where the Northeast Kingdom and us are very similar, is that we have these deep pockets of really rural areas.
Kristi.
Yeah, I agree with Betsy on that. And it makes it very difficult in those rural areas because the only transportation into healthcare is by automobile. And if it's a family that happened to have only one car and that car goes in the morning because somebody has to get to work, then the rest of the family are left all day without anything.
Yeah.
It's a real serious problem in the rural area.
Yep.
Or if it's an older person or couple. I just sold a woman's house up in Sandgate. She was 80, you'd never know it, but it was because her kids were worried. It would have taken her 40 minutes on her own to get to the hospital. If it was her, she wouldn't have gotten there.
Yeah.
But I also wonder, Kristi, is any of it like our proximity to cities where drug use is coming up? Does that play a role too?
With that particular slide I showed, probably not. But we do know that the primary source of fentanyl, which is 88% of the death rates, is coming from Boston. So it makes sense that it's going right into Brattleboro, Windham County, over into Bennington, and probably Albany. But I don't think that's the major contributing factor to why our health outcomes are so bad. Population health data, in particular for rural communities, is a challenge because there's not enough people for it to be a robust study. So some of the things that we're doing here locally are based on urban studies that don't maybe apply to our community and what we're trying to do. So it's difficult to filter through those and to tease out what makes the most sense.
Now, one other thing you could clarify for me, for my benefit at least, is that what is the larger umbrella under which you work, or, you know, from a direct employment standpoint?
I work for SVMC, so I am 100% an SVMC employee. A lot of folks think that Blueprint for Health is a separate organization, sort of taking up space at SVMC. Even internal SVMC folks think that, and it's okay. But it's actually a program implemented by SVMC. SVMC is the administrative entity, so you wouldn't be able to look up a specific organization with a tax ID, and here's Blueprint for Health. It's not. It's money filtered into SVMC to implement the program.
Okay,
It's a
thank
great
you.
question, and I always confuse everyone.
Thank you.
All right. Any other questions for Kristi? Thanks, Kristi. That was really informative.